Hello everyone. Today we will be talking about a case which is a patient who has a mature intumescent cataract after corneal transplant. When we look at the biometry, we see she has about 5 diopters of cylinder which is at 90 degrees and the axis was also corresponding on the pentacam. So we decided to put a Toric IOL for her because now we can correct this post-PK astigmatism also when we are planning the cataract surgery. So here I am making the side port incision, taking care that I do not enter at the graft and the incision is made only on the host side. I do not want to enter the graft host junction. After staining the anterior capsule with trypan blue, we are going to go ahead with Rexis, and I'm using a cohesive viscoelastic as this is a very intumescent lens. So I want to pressurize the chamber from the top so that the fluid inside, and since the intralenticular pressure is high, it makes it easier for me to do the capsulorhexis and we do not have a rhexis which runs away. So I decide to make the other rhexis as well, other side port as well, because I want to use rhexis forceps here to create the rhexis. So I'm being very gentle. I've put in some more viscoelastic. Now this was a dispersive one and I am carefully and slowly using the rhexis forceps, keeping the forces always towards the center, that is the centripetal forces. So see how I am moving my rhexis forceps, making sure that it doesn't run out and always the direction is pointed in a centripetal fashion. This avoids running of the rhexis in such cases, and the rhexis forceps gives us a far better control than a cystitome. So now that we have achieved a decent sized rhexis here which is continuous, I'm going ahead with phaco. This is a very soft cataract. It's just a 23-year-old patient. So we are just using the minimum phaco energy and the whole of the lens just comes out, and here then we are going ahead with the bimanual irrigation aspiration to clear off all the cortex here. So as much as possible we are clearing off the cortex. There's some cortical material which is actually stuck to the anterior capsule and it is quite fibrosed, and those fibers we are trying to just loosen them up a little bit as much as possible and trying to do a thorough cleaning, but not trying to put excessive pressure anywhere on the zonules. And this is the lens going inside the eye. So we have put the Toric IOL inside the eye now and we are aligning the marks at 90 degrees. Make sure that there's no rotation and clearing off all the viscoelastic. And before we remove the infusion, I am placing an air bubble so that this helps in preventing chamber collapse and rotation of the IOL. Then we are sealing all the incisions here, and this is the end of the case. Thank you for watching.